Thank you for inviting me, and nice to see so many old faces. So I was asked to talk about bispecifics and a little bit about what's new in transplant. So I'm going to get rid of the transplant part up front because there's not much new. But I'll kind of tell you where we are with the role of that. Here are my disclosures. And this is just hot off the press, the MSMART guidelines. And what you can see here is for transplant-eligible patients, currently the standard of care is a quadruple drug induction regimen like Dara-VRD or Isa-VRD, and then follow that up with stem cells. For standard risk patients, I'd say doing the auto transplant, it's really a conversation with your physician. We've done studies which have shown improvement in the depth of remission, but as far as survival differences, we're really not seeing that. I think most of us would agree that if you have high-risk disease, that we should proceed to the transplant and not just collect stem cells. So, but I think this, as some of the data I'm going to show you, is the role of transplant is going to be in flux over the next decade, I suspect, and utilization will probably decline. Right now, it's still an effective treatment and what we would consider standard of care. But in the future, as you've already heard about today with some of these newer treatments, particularly working on your immune system, the responses we're seeing are quite amazing. And you wonder how much more mileage you're going to get with something like a transplant added in. But we'll go over some of that data, okay? So just to tell you a little bit about bispecifics, I thought I would take you to, I didn't want to make this too complicated, but maybe this slide is a little too complicated. But it shows you how our T cells, which are part of our immune system, really talk to what we call antigen presenting cells, which present antigens for example, if you have a bacterial or viral infection, that's taken up by the antigen presenting cell. It presents antigen through this major histocompatibility complex, the MHC, to T cells. And this interaction is mediated by something called the T cell receptor that all T cells have. And then there's also a co-stimulatory signal that usually needs to happen. And this is what turns on the T cell. It's like going and turning on a switch at your house to turn the lights on. That's how T cells get activated. And when they get activated, then they start doing things like secreting hormones and cytokines and granules, and they start attacking infections and also cancers. So this basic mechanism, as we started understanding this, then we started developing technologies that could manipulate this. So the first technology was something called a BiTE, right? And a BiTE is basically a precursor to the bispecific antibody. And let me see, oops. Right here, what you can see is a little molecule where one of the proteins here will go and bind to a target antigen on a tumor cell. In this case, the first BiTE that was designed was blinatumomab, which targets a leukemia cell, which has something called CD19 on top. And then the other part targets the T cell receptor, a component of that called CD3. And when you get this connection, what basically happens is I describe it as two hooks. One hook binds to your tumor, and the other hook binds to your T cell. And the hooks basically bring the T cell and the tumor cells together. And then this sort of activates the T cell. We call this an immune synapse. And essentially, the T cell gets triggered to now kill the cell. Okay? One of the issues with this is that this is a very small molecule, so the way we had to administer this was by a continuous infusion pump. So for 28 days, you'd have to wear a pump, and it had to be going in constantly, because if you stopped it a few minutes later, it was kind of out of your system. So that's kind of a nightmare to operationalize in a treatment setting. So we had to evolve. And, one thing that we had to evolve was identifying targets. So for myeloma, for whatever reason, we got tons of targets to go after. So one of the most common targets that you've seen already discussed is B-cell maturation antigen, or BCMA. There's another target called GPCR5D, which is also being targeted. Sometimes we don't really know what these things do, but they're good flags on the surface of myeloma that we can go and attack. And other targets like CD38, this is what Darzalex and isatuximab bind to, SLAMF7, elotuzumab. So, some of these we've made antibody drugs against, but potentially you could make a bispecific or a BiTE molecule against any of these. All you have to do is get the right pieces together. It's like putting Lego blocks together, right? And that's essentially what we've figured out. But there are some issues with this. If you have to give it as a continuous infusion, that's a downside. So how do we get around that? Well, fortunately, we have antibody structure that helps us. So this is what an antibody looks like, okay? And bispecifics are just antibodies. So just one portion here binds to your tumor cell, the other portion binds to your T cell, but this third portion here allows the antibody to float in the blood and stick around for a long time. So if you get an injection, this component will allow the antibody to stay in a long time, so you don't have to do this continuous infusion. So that's really the advent of bispecific antibodies. That's how this all started. So pretty much now we can mix and match and play, and we can, modify these structures and kind of like Lego blocks, put different pieces together, and we can do some pretty cool things. So here's a little update on this, and this is very active space right now. So we've had a whole bunch of drugs that have been FDA approved. We have 3 drugs that target B-cell maturation antigen, Tecvayli, Elra, and also Linvo. And this slide's a little old, so this needs to be updated, so I apologize. This was one of the original Amgen drugs that was a BiTE, where this had to be infused kind of 28 days. And you can see that's a smaller molecule, but these other ones, they have this third component that allows it to float around for a lot longer. So this allows for subcutaneous injection and a more outpatient-friendly schedule. Then we have other targets like GPRC5D, and talquetamab is a drug that's approved that targets this. And we have other drugs that are not FDA approved that are still in study, like cevostamab, that targets another target on the surface, which I always forget if it's FCH something. But they all have long names, and I really don't know what any of these targets do, but all I think of them as they're flags, and we can go hit them with our drugs. So what do we have to worry about with these bispecifics? Same thing like with CAR T, we have to worry about some side effects. When we activate these T cells, sometimes they get really pissed off, and they start doing all sorts of crazy things. Like they make you feel like you had the worst case of the flu or a really bad case of COVID, and that's because your immune system just got turned on to go attack, right? And sometimes we're not just turning it on, we're just slamming on the gas pedal and making those guys go full force. So when that happens, the T cells secrete cytokines. They bring all their buddies that are part of their immune system to come to war, and they go after the cancer like blitzkrieg, and that can make people feel bad. That syndrome is called cytokine release syndrome, and the hallmark of that is that these cells are secreting cytokines. These are hormones that they're using to communicate, and one in particular is called IL-6. That one we see at high levels, and that's bringing all these guys to do their job. So when that happens, that can be a problem. People don't feel very good. And this is a relatively new toxicity that we've learned in the world of immunotherapy, and how do you manage that? And sometimes people get sick. So, if you get a shot that makes you feel like really, really bad, do you want to keep doing that, right? So that's one important component of managing that. And most patients who respond to these treatments, they do get this cytokine release. So we want the Goldilocks variety, right? We want the porridge to be lukewarm where we can eat it. If it's too hot, it's not good. It's going to burn you. And if it's too cold, it means it's probably not working. So how do we toggle that? So cytokine release can affect a lot of your organs. It can affect your heart. People can go into heart failure. It can affect your lungs. Lungs can fill up with fluid. Blood pressure can drop. Blood counts can go really, really low. The coagulation system in the blood can be screwed up, and you can have bleeding or clotting. So lots of things can go wrong. But the one that really scares people is the neurologic toxicities, and sometimes those can be pretty dramatic. It's much more dramatic when we treat patients with CAR T. The risk there is higher, but it's not zero with the bispecific antibodies. And it's to the point where if you've seen somebody have these, it's almost like, they're sitting in front of you and they can't talk to you. And they're just staring at you blank in the face. Or sometimes it's like, if it's really bad, they're like in a coma and you can't wake them up. So it can be pretty scary for family members. And you're like, Doc, you just gave my family member this treatment and now they look horrible, right? So, but again, understanding what the basis of this toxicity and how often it happens is kind of important, and managing this toxicity, again, is important. So the good news is, the bispecifics, this rarely happens. So it has a much nicer safety profile. The other thing about bispecifics is if something bad happens, you can stop it and it usually goes away. Versus CAR T, you're actually putting T cells into the body, and once you put them there, they're gonna live there for the rest of your life. So you can't really toggle that on and off like with bispecifics. So some advantages, some disadvantages with these different modalities, but they're all using your immune system to fight the cancer, which can be profoundly effective. All right, so what are our antidotes? Well, we got two. One is called tocilizumab. You remember I told you about this hormone IL-6, which goes up at very high levels. So we can give a drug that blocks that hormone, and boom, the side effects go away. So I've seen people that have fevers to 103, 104, we give this drug and boom, it's gone. It's like taking Tylenol. Everything just gets better and they feel so much better. So if you know what's causing the problem, you can address it, right? So, and most of the time with bispecific antibodies, we don't really need to use this. We can just deal with it with Tylenol. For CAR T, we tend to use this much more frequently. And the other drug that we use a lot is steroids. And mostly we use that for this neurotoxicity. We called this immune effector cell associated neurotoxicity syndrome, or ICANS. It's a lot to get out. But again, with these bispecifics, it can be seen, but the rates are typically low. And it's often associated with that cytokine release. It kind of happens at the same time usually. And this is why one of the challenges with uptake of the bispecifics has been, hospitalization. So you get the bispecifics, you got to ramp them up. You can't just get the full dose, because that's like slamming on the gas pedal and your car's going really, really fast. You got to start with this low dose, then go to a slightly higher dose, and then ramp up to the full dose. And typically, the FDA has recommended that people go into the hospital for each of these doses and be monitored. Now, sometimes that's just not feasible where people live. One, the hospitals don't know how to do it. They don't always have the drugs. It can be a barrier for administration. But I think this is where all of us have been doing some work to get this out to doctors' offices, so you don't need that component. You can do it safely by just getting the shot at your doctor's office and maybe taking some preventative measures so that people don't need to go into the hospital, okay? So one nice thing about the bispecifics is that you can, avoid hospitalization for the most part. So I'm not going to spend too much time on these slides, except to show you that these are some of the studies that led to the approval of the bispecific. So this is Majestic 1. This led to the approval of teclistamab. And what I want to highlight here is these were really sick people. So most of the patients that went on this clinical trial, they had seen every drug under the sun for myeloma. And despite that, we got response rates of about 70%. So when I think about that, when I get a new drug, if I get a response rate of 20% for a very refractory population of patients, I'm doing jumping jacks. At 70%, I'm like, whoa, that's a home run. Okay? Just to keep it in perspective, if we talk about CAR T cells, the response rates are in the 90%, 90 to 99%. So, but 70 is not that bad, pretty close to 90, and you don't have to go through all the rigmarole of collecting your T cells and all that. So it's a nice advantage in that regard. And then you can see the CRS rates, that syndrome we talked about. Most people got it, 70%. Majority of it was mild, but most people still got it. So this can scare folks, and how do we manage that, right? How do we make sure that I don't feel really bad when I'm doing this drug, where if I take one dose, I feel so sick I don't want to take the next one. We gotta manage that, right? So this teaches us something. And then if you see the neurotoxicity is pretty low, it's 3%. So if we look at another compound, this is elranatamab, similar, again, targeting BCMA, again, a very similar profile, okay? It looks very, very similar. And I've used both of these drugs, and they work really well. This is a slightly different version. This is from AbbVie, a slightly different design, and this is where we can get really interesting design of these molecules, where this one binds to BCMA, but when it binds to the T cells, it doesn't bind as strong. So hopefully what that means is we get less of that cytokine release, but we still get the same level of activity. So again, you can see how you can mix and match things and put different components and perhaps get better toxicity profile. So this one is currently in clinical trials. This one's not FDA approved, okay? This is another drug called talquetamab, which binds to GPCR5D. Again, very similar, all these slides where you're seeing really, really high response rates in very refractory populations. This one's kind of unique because there's some unique toxicities with this. It can affect your skin, it can affect your nails. And the one that people complain the most about is their tongue. Their mouth is dry, and they often lose their taste. And again, we've learned how to manage some of these symptoms by modifying the dose to monthly dosing, where people tend to do a little bit better. So some of the complications we talked about, the need for hospitalization for that ramp up and for that monitoring. And here, we're doing a lot of work on trying to prevent this. I think most people now feel pretty comfortable doing these in the outpatient setting. One way of doing this is giving a dose of that drug tocilizumab right before you're about to start. You block all those inflammatory signals, and you just need one dose, and you can do the next couple of doses, and people do very well. The other thing I often do is just give everybody their favorite drug, dexamethasone, and give a good dose before, give a good dose after. Their spouses are usually angry at me for the next week, but we get them through the period of fever and all these side effects. If they have a fever in the middle of the night, we just have them pop a little bit more dexamethasone, and usually takes care of it. And that way we keep them out of the hospital and everybody's happier, okay? And we don't need to do that forever. We just need to do that maybe for the first week. So these strategies are being studied in clinical trials, and people are actually doing them in practice also. So I foresee the majority of these are going to be done in an outpatient setting. But there are a couple of important components that we need to think about with bispecifics. One is viral infections, particularly with BCMA targeting agents. I've seen responses where your light chains are so low they're undetectable with these drugs, but then people keep getting colds, the flu, other viral illnesses. Sometimes weird viruses like cytomegalovirus, and that can happen in your eye sometimes. So we got to monitor for these things. And again, once you monitor and you're treating these, it's not so much of a big deal. But if you're not, that can be a problem and can sometimes lead to catastrophe. So I typically do prophylax patients with gamma globulin at least once a month, especially during the winter months. Then there is the oral and nail toxicity, and this is an off-target effect of targeting this protein GPCR5D. It's on the nails and it's on the tongue, and that's why the antibody just goes and takes the T cells to those areas, and those areas get damaged. And that can be not fun, but again, with monthly dosing, people seem to do better. So what are the upsides with the bispecifics compared to CAR T? The upsides are you can snap your fingers and you can do it. Not exactly, but it's off the shelf and ready to go. CAR T, we still have to manufacture, so we have to collect your T cells, make it. The CAR T typically works better. The response rates are higher, but there's a lot more involved in it. And so bispecifics, though, if 70%, that's pretty good. It's not 90, but it's close. So if I can't wait on somebody, this is a way to go. Typically, we try to do the CAR T first because the bispecifics still work pretty well after CAR T failures, and the other way around, it's not as good. But sometimes we don't have an option. One big hindrance right now is we got to wait on these lines of therapy definition, which often burdens us. So, one line of therapy, like was mentioned earlier, is your induction, autotransplant, and maintenance is all one line. To me, that sounds like 3, but that's just 1. So we count a little bit different. And I hope in the future we go to more class refractory, which makes more clinical sense. But right now, these are approved after 4 lines. So it's still quite a bit of treatment that people need to get before they're eligible for this. But I think that's going to rapidly change as we get more data from clinical trials, and these things will go closer up front. And to highlight that, I think I have some slides here, some study designs of some trials that are ongoing right now, and all the different varieties are doing the same thing. I'm just highlighting these because I had these slides from one of my colleagues, where we're giving one of the BCMA bispecifics early on, as you can see, and then moving to chemotherapy, and then doing maintenance, okay? So again, when we look at this, looks like the slides maybe, well, what they're supposed to be showing you is that the rates of remission are like close to 100%, where we're not detecting any level of minimal residual disease. So again, with the maintenance setting up front, and then this is basically looking at doing it, early on with lenalidomide, and I'm sorry the slides aren't projecting, but they're showing the same things at the bottom here. 100% of the patients are MRD negative. So what this is really highlighting is if we incorporate these newer therapies earlier on in the course of treatment, we're getting deep, deep, deep remissions. If you do that, can you de-escalate treatments? Can you use MRD as a marker to follow response and use that to stop treatment for some patients? or avoid certain treatments, like how much is a transplant really going to add if you're already pretty close to the bottom, right? It might add a little bit, but you can start having conversations about how effective it is. So we've come a long way. Unfortunately, I can say this, I'm old enough. When I was training, we had 2 drugs, and thalidomide was just making its way in. And boy, how exciting it is to see some of these drugs, like these bispecifics, because if you've ever taken care of a patient where you don't know what to do, and you put one of these drugs in, and you're like, oh my God, they're walking, they were bedbound before, and now they're out living their lives. It's very, very rewarding. So the future is very, very bright. And I want to highlight what the future is, right? And I think more engineering here. We can see here, I'm going to show you a little bit more about this in the next slide. This is a trispecific. So we can target 2 things at one time, and we can combine with Revlimid, Pomalyst, daratumumab, and I think we're starting to see results where when we combine these different combinations, we're seeing pretty dramatic results. Here is the trispecific that we hope to have here in Austin soon, where we're looking at targeting 2 different compounds, BCMA and GPCR5D, and do it in a way where we can give it outpatient and do it in a schedule that's maybe more comfortable to people, like once a month. Again, there's a lot that we have to learn about this, but what was really exciting is this drug was presented at one of our conferences, and the response rates were 100%. I mean, things that we've never heard of before, that everybody who got this drug got better. So again, right now, this drug is available for people who have relapsed refractory disease, but you know, as we start learning more about this and incorporating it earlier, you know, we have a lot of riches in myeloma right now. So one of the questions becomes, how do we sequence all of these things? And that's still very complicated, and I still don't know. That's why I defer to my myeloma experts like Dr. Patel, Dr. Matsui, and I called them and asked them for advice on how to do all of this. When do you do the CAR T? When do you do the bispecific? Sometimes it's very obvious because you know the choice is made for you by the clinical situation, but other times when you do have choices, it is important to think about this and sequence this in the right way. So a lot of good options for the future, and this I think is just scratches the surface. We might be able to combine these things together, like CAR T and bispecifics together. So there's a lot of interesting things that are happening, and it's a very exciting time. And it's really turning myeloma into a very chronic illness, where it's similar for many people, like getting diagnosed with diabetes or high blood pressure, where you know you have to go to your doctor, you have to get some treatment, occasionally you have to make some adjustments, but you're living with the disease, and it's not you're not dying of the disease. And that's what I tell most of my patients is, you know, especially for good risk myeloma, plan on, you know, living a long time and you know, make sure that you enjoy that time. So with that, I'll stop and happy to answer any questions.